Jet ventilation. Description: 1. High-pressure gas delivery into an open airway. 2. Passive exhalation. 3. Significant risks due to unfamiliarity and potential misplacement. Types: A. Low-frequency jet ventilation. Description: 1. Manually driven injector system, e.g., Manujet. 2. Delivers high-pressure gas jet into airway. Methods: 1. Cricothyroidotomy needle cannula, placed through cricothyroid membrane under local anesthesia, aimed towards carina. 2. Jet catheter, rigid, non-compliant catheter, tip placed midway down trachea. 3. Injector needle, attached to operating laryngoscope, rigid bronchoscope. Ventilation starts when aligned with larynx trachea. Considerations: 1. Risk of catastrophic consequences if cannula misplaced, misdirected. 2. Inadequate gas exchange common. 3. Technique requires experience and caution. B. High-frequency jet ventilation. Description: 1. Specialized ventilators deliver high-frequency gas jets, 110 Hz. 2. Warmed and humidified inspiratory jets. 3. Electronically controlled. V. Key features: 1. Adjustable parameters, frequency, driving pressure, inspiratory time, gas composition. 2. Air entrainment, delivered 5 s vary. 3. Monitoring, airway pressures, cutoffs and safety features, inspiratory pauses for accurate C02 sampling. Benefits: 1. Effective ventilation with smaller tidal volumes. 2. Useful in airway surgery and lung protective strategies. Considerations: 1. Requires experience and specialized equipment. 2. Careful monitoring and adjustment of parameters. Indications of jet ventilation: 1. Emergency airway management, transtracheal cricothyroid membrane cannula. 2. Airway surgery, laryngeal tracheal stenosis, major conducting airway surgery. 3. Thoracic surgery, lung isolation techniques. 4. Lung protective ventilation strategies in ICU. Safety considerations: 1. Monitor airway pressures. 2. Cutoffs and safety features. 3. Inspiratory pauses for accurate CO2 sampling. Parotidectomy, procedure, excision of parotid gland, usually preserving facial nerve. Time duration: 2-5H. Pain, +++++. Position: supine, head ring, head tilted to side and moderately extended, head up tilt. Blood loss, small moderate, G and S. Greater for malignancy. Practical techniques: south-facing ray tube and IPPV normally used, though SV possible for suitable patients. Reinforced LMA and IPPV or SV also possible. No NMB during dissection around facial nerve. Anesthesia for parotidectomy. Preoperative: 1. Assess suitability for spontaneous ventilation SV. 2. Check mouth opening, especially if malignant. Perioperative: 1. Forced air warming blanket, fluid warmer, and urinary catheter as needed. 2. Avoid NMB after initial dose to allow facial nerve testing. 3. Remifentanil infusion ideal for PPV without NMB and reducing blood loss. 4. Alternative: suppress respiratory drive with opioids, volatile agents, or propofol infusion. 5. LA spray to larynx to prevent coughing. Postoperative: 1. Continue remifentanil or give morphine before end of surgery to prevent agitation and hypertension. 2. Keep head up and treat hypertension early. 3. Antiemetic and analgesia is required. Special considerations: 1. Surgeon may use nerve stimulator to identify facial nerve. 2. Large bore IV access recommended due to potential bleeding. Nerve blocks, Oxford, a cervical plexus block. V. Indications: 1. Analgesia or anesthesia for carotid surgery and superficial neck procedures. Positioning: 1. Lateral or supine with head turned to contralateral side. Technique: 1. Ultrasound-guided intermediate block of superficial cervical plexus nerves. 2. Identify C7 and C6 transverse processes, then C5 and C4. 3. Block usually performed at C4 level. 4. Identify lateral border of sternocleidomastoid muscle SCM. 5. Target plane between deep border of SCM and deep cervical fascia, prevertebral fascia. 6. Insert needle in plane from posterior, infiltrating the plane and surrounding nerve-like structures. Landmark technique for cervical plexus block. 1. Injection point, midpoint of posterior border of sternocleidomastoid muscle SCM. 2. Inject 10-15 ml local anesthetic fand along posterior border of SCM, cephalad and caudad. Side effects and complications. 1. Superficial block, minimal side effects. 2. Deeper insertion, risk of phrenic, recurrent laryngeal, and brachial plexus block. 3. Nerve injury and hematoma possible. Precautions. 1. Rarely indicated for deep cervical plexus block. 2. Caution in severe respiratory compromise or contralateral phrenic palsy, interscalene brachial plexus block. Indications. 1. Analgesia for shoulder surgery, positioning, lateral or supine with head turned to contralateral side, ultrasound technique. 1. Visualize brachial plexus roots between scalene muscles. 2. Identify C5, C6, and C7 roots. 3. Posterior in plane approach is popular, landmark technique. 1. Insertion point, level of cricoid cartilage, lateral to SCM. 2. Direct needle towards contralateral elbow. 3. Nerves are superficial, depth S 2.5 cm, nerve stimulation. 1. C5, deltoid twitch. 2. C6, biceps twitch. 3. Phrenic nerve stimulation, needle to anterior. 4. Levator scapulae stimulation, needle to posterior, volume. 1. 10 ml with ultrasound. 2. Traditionally 20-40 ml with landmark technique. Side effects and complications. 1. Phrenic nerve block. 2. Horner syndrome. 3. Recurrent laryngeal nerve block. 4. Nerve damage. 5. Vessel puncture. 6. Pneumothorax. Precautions. 1. Perform on awake or lightly sedated patients. 2. Avoid in severe respiratory disease and contralateral phrenic nerve palsy, supraclavicular brachial plexus block. Indications: analgesia or anesthesia for distal humerus, elbow, forearm, wrist, or hand surgery. Positioning: supine or semi. Reclined with head turned to contralateral side. Ultrasound technique. 1. Probe parallel encephalad to clavicle, in supraclavicular fossa. 2. Brachial plexus appears as triangular-shaped bunch of grapes lateral to subclavian artery. 3. Image plexus on first rib, not on pleura, to reduce pneumothorax risk. 4. Use color Doppler to identify vessels, such as dorsal scapular artery, volume. 20-30 ml to surround plexus, nerve stimulation, finger flexion or extension twitches. Side effects and complications. 1. Horner syndrome. 2. Phrenic nerve block. 3. Pneumothorax. 4. Artery puncture. 5. Intravascular injection. Tips. 1. Use color flow Doppler to identify vessels. 2. Avoid in severe respiratory disease and contralateral phrenic nerve palsy. 3. Inject in corner pocket between artery and first rib for higher success rate. 4. Suprascapular nerve may have left plexus at this level, traveling posterolaterally under, omohyoid, axillary brachial plexus block. Indications: 1. Anesthesia for hand surgery. 2. Analgesia for forearm, wrist, or hand surgery. Positioning: supine with arm abducted to 90 degrees. Ultrasound technique. 1. Probe positioned high in axilla along axillary crease. 2. Image axillary artery and short axis. 3. Identify nerves: median nerve, superficial and anterior; ulnar nerve, superficial and posterior; radial nerve, deep and posterior; musculocutaneous nerve, between biceps and coracobrachialis or in coracobrachialis. Nerve stimulation. 1. Radial, thumb, wrist, or finger extension. 2. Ulnar, adduction of thumb, little finger flexion. 3. Median, finger and wrist flexion, pronation of wrist. 4. Musculocutaneous, biceps and brachialis contraction, volume. 20 ml. Complications: 1. Artery puncture. Compress for SMIN if occurs. 2. Intravascular injection. Precautions: 1. Highly variable anatomy. 2. Follow nerves from arm to axilla for identification. 3. Multiple veins may be present. 4. Avoid IV injection, aspirate and observe LA spread. Intravenous regional anesthesia. Beers block. Indications: 1. Anesthesia for superficial arm surgery or fracture reduction. 2. Maximum operation length limited to about 30 minutes. 3. Can be used for lower limb. Technique 1. Measure patient's BP. 2. Insert IV cannula into limb requiring surgery and another limb. 3. Apply double or single cuff tourniquet to upper arm. 4. Exsanguinate limb with compression bandage or elevation. 5. Inflate cuff to 50-100 mmHg above systolic BP. 6. Use non-adrenaline containing L-prilocaine 0.5% or lidocaine 0.5%. 7. Inject slowly. 40-60 milliliters depending on arm size. Precautions. 1. Warn patient of warm sensation and mottling. 2. Do not deflate cuff before 15 minutes, prilocaine, or 20 minutes lidocaine. 3. Use double cuff for tourniquet pain. 4. Contraindicated in circulatory difficulties, crush injury, SED, peripheral vascular disease, V complications. 1. Local anesthetic, systemic toxicity. Last, anatomy of nerve supply to thorax and abdomen. 1. Spinal nerves T2, T1-2 supply muscles and skin of chest and abdomen. 2. Mixed spinal nerves divide into dorsal and ventral rami. 3. Dorsal rami supply deep muscles and skin over dorsum of trunk. 4. Ventral rami form intercostal nerves, thoracic paravertebral block. Indications. 1. Analgesia for breast surgery, thoracic surgery, open cholecystectomy, renal surgery, or fractured ribs. Positioning, sitting or later. L. Ultrasound technique. 1. Imaging paravertebral space is difficult due to depth and bone shadows. 2. Identify transverse processes and pleura. 3. Use sagittal or transverse probe orientation. 4. Needle approach, in plane. P, or out of plane, 00p. 5. Use bony landmarks and hydrolocation for needle tip identification. Landmark technique. 1. Palpate spinous processes. 2. Needle insertion point. 2.5 centimeters lateral to cephalad aspect of spinous process. 3. Contact transverse process at 2-4 centimeters depth. 4. Redirect needle cephalad to transverse process. 5. Use loss of resistance technique or insert 1 centimeters further. Volume, 5 ml per level or 20 milliliters at single level. Side effects and complications. 1. Epidural spread. 2. Sympathetic block. 3. Pneumothorax. 4. LA toxicity. 5. Intravascular injection. Tips. 1. Keep needle tip in ultrasound image to reduce pneumothorax risk. 2. Consider alternative blocks, erector spini plane or retrolaminar, if imaging or block performance is difficult. Mid-axillary transversus abdominis plane TAP block. Indications, analgesia for incisions to the lower abdominal wall. Ultrasound technique. 1. Place probe on lateral abdominal wall between costal margin and iliac crest. 2. Image 3 muscle layers, external obliqueo, internal oblique, and transversus, abdominis TA. 3. TA is thinnest and most hypoechoic layer. 4. Target plane is between Li0 and TA. 5. Use in plane technique with needle coming from anterior. Landmark technique. 1. Perform block and triangle of Petit. 2. Located above iliac crest, with the O muscle forming anterior border and latissimus dorsi forming posterior border. 3. Feel 2 pops as needle passes through fascia and muscle layers. Volume, 20-30 milliliters per side. Complications. 1. Puncture of bowel. 2. Intrahepatic or intrasplenic injection. 3. Local anesthetic, systemic toxicity. Last, tips. 1. Be careful with LA dose when performing bilateral large volume block. 2. Subcostal TAP block can be performed to cover incisions from T8 to T10. Rectus sheath block. Indications, analgesia for upper midline abdominal incisions. Ultrasound technique. 1. Place probe in transverse orientation on anterior abdominal wall. 2. Identify 3 lateral muscle layers, linea semilunaris, rectus muscle, and peritoneum. 3. Target plane is between rectus muscle and posterior rectus. Target plane is between rectus muscle and posterior rectus sheath. 4. Use in plane technique from later. L. Landmark technique. 1. Mark 4.5 cm cephalad lateral and 5 cm caudad lateral to umbilicus. 2. Insert needle through skin and SC tissue. 3. Feel 2 resistances, anterior rectus sheath and posterior rectus sheath. 4. Inject 10-15 milliliters after feeling second resistance. Volume 20-30 milliliters per side. Complications: 1. Bowel puncture. 2. Local anesthetic. Systemic toxicity. Last tips: 1. Beware of superior epigastric vessels in this plane. 2. Perform bilaterally for midline incisions. 3. Not possible below arcuate line due to absence of posterior rectus sheath. Fascia iliaca block. Suprainguinal technique. Indications: 1. Analgesia for fractured neck of femur. 2. Analgesia for hip surgery. 3. Femur and anterior and lateral thigh analgesia. Positioning: 1. Supine. 2. Flatten bed to open hip flexion. 3. Tilt bed head up if necessary. Ultrasound technique. 2 techniques: infrainguinal and suprainguinal. A. Infrainguinal technique. 1. Place probe in transverse orientation in inguinal crease. 2. Identify femoral artery and vein. 3. Locate fascia iliaca deep and lateral to artery. 4. Insert needle from lateral end of probe. 5. Aim to place LA under fascia iliaca, lateral to neurovascular bundle. B. Suprainguinal. Place probe over ASIS in parasagittal orientation. Identify bow tie appearance of iliacus muscle, eo muscle, and sartorius. Fascia iliaca is hyperechoic fascial layer covering iliacus muscle. Insert needle from caudate end, aiming for LA spread under fascia iliaca. Landmark technique: 1. Find junction of middle and lateral thirds of inguinal ligament. 2. Move 2 cm distal and 2 cm later L. 3. Needle passes through fascia lata first pop and fascia iliaca, second pop. Volume 30-40 milliliters. Complications: 1. Vascular puncture. 2. Nerve injury. 3. Local anesthetic. Systemic toxicity. Last. 4. Intraperitoneal injection. Tips: reliably blocks femoral nerve and usually lateral femoral cutaneous nerve. Obturator nerve is usually spared. Femoral nerve block. Indications: 1. Analgesia for hip, knee, or femoral shaft surgery. 2. Combined with sciatic nerve block for lower leg surgery. Positioning: 1. Supine. 2. Flatten bed to open hip flexion. 3. Tilt bed head up if necessary. Ultrasound technique: 1. Place probe in transverse orientation in inguinal crease over femoral vessels. 2. Identify femoral vein and artery. 3. Stay proximal to avoid artery division. 4. Femoral nerve is hyperechoic honeycomb structure between iliacus and fascia iliaca. 5. Advance needle from lateral end to penetrate fascia iliaca. Landmark technique: 1. Palpate femoral artery beneath inguinal ligament. 2. Insert needle 1.5 cm lateral to artery, 1 cm distal to ligament. 3. Feel 2 pops as needle passes fascia lata and fascia iliaca. Nerve stimulation. Patella dance. Volume 10-20 megaliters. Complications: 1. Arterial puncture. 2. Intravascular injection. 3. Nerve injury. Tips: 1. Imaging difficulty often due to scanning too distally. 2. Femoral nerve flattens and divides distal to inguinal ligament. 3. In obese patients, abdominal pannus retraction may be required. Popliteal sciatic nerve block. Indications: foot, ankle, and lower leg surgery. Positioning: lateral, supine, or prone. Ultrasound technique: 1. Place probe transversely in popliteal fossa. 2. Identify popliteal vessels and tibial nerve. 3. Trace tibial nerve proximally to identify common peroneal nerve. 4. Block performed where nerves are enclosed in common sheath. Landmark technique: 1. Lateral approach, supine, with knee slightly flexed. 2. Mark groove between vastus lateralis and biceps femoris. 3. Insert needle 22G 100 mm, directed posteriorly 25 to 30 degrees and slightly caudally. Nerve stimulation: 1. Common peroneal nerve, foot dorsiflexion and eversion. 2. Tibial nerve, foot plantar flexion and inversion. Volume 20 milliliters. Tips: 1. Block more distally if junction location is too deep. 2. Beware of sural nerve branches if blocking too distally. 3. Anisotropy prominent, tilt probe to maximize nerve brightness, adductor canal and distal femoral triangle blocks, indication, saphenous nerve and nerve to vastus medially blocked for total knee replacement, positioning, supine with hip slightly flexed and externally rotated, ultrasound technique. 1. Place probe transversely over enteromedial aspect of mid-thigh. 2. Identify femoral artery with sartorius muscle superficial to it. 3. Target area lateral to artery deep to vasoductor membrane. 4. Pass needle and plane from lateral end of probe, volume, 10 ml, complications, artery puncture, tips. 1. Ensure LA spreads deep to vasoductor membrane lateral to artery. 2. Mid-thigh level is usually a distal femoral triangle block. 3. Sliding distally becomes an adductor canal block blocking saphenous nerve only, ankle block, indications, analgesia or anesthesia to the foot, positioning, supine or lateral, depending on nerve, ultrasound technique. 1. Tibial nerve, place probe proximal to medial malleolus, identify posterior tibial artery and veins. Nerve lies posterior to vessels, pass needle and plane from posterior end. 2. Saphenous nerve, place probe over anteromedial ankle, identify greater saphenous vein, nerve runs in close proximity to vein, pass needle from posterior end to surround vein. 3. Deep peroneal nerve, place probe over anterior ankle joint, identify anterior tibial artery, nerve is small hypoechoic circle passing over artery, pass needle and plane from medial or lateral L. 4. Superficial peroneal nerve, place probe on lateral aspect of fibula. Nerve exits plane to continue distally in SC plane, identify intermuscular fascial plane, pass needle and plane from anterior or posterior. 5. Sural nerve, place probe over posterolateral leg, identify lesser saphenous vein, nerve is near vein, pass needle and plane from anterior or posterior, landmark technique. 1. Tibial nerve, inject behind tibial artery. 2. Saphenous nerve, infiltrate ring of LA from medial malleolus to tibial ridge. 3. Deep peroneal nerve, insert needle lateral to dorsalis pedis artery. 4. Sural nerve, raise SC wheel of LA from lateral malleolus to Achilles tendon. 5. Superficial peroneal nerve, infiltrate SC medially and laterally over dorsum of foot, volume 1, 2-5 milliliters each with ultrasound. 2.5-10 milliliters each with landmark technique. Side effects and complications. 1. 5 injections can be painful. 2. Arterial puncture. 3. Nerve injury. Tips. 1. Proximal tourniquet helps with vein filling. 2. Saphenous nerve block not required for forefoot surgery. Erector spinae plane block. Indications. 1. Chest wall analgesia e.g., rib fractures, thoracotomy, breast surgery, when paravertebral block is high risk or difficult, positioning, sitting or lateral, ultrasound technique. 1. Place probe in sagittal plane over midline spinous processes. 2. Slide laterally to identify transverse processes. 3. Identify erector spinae muscle superficial to transverse processes. 4. Insert needle and plane from caudate end of probe. 5. Aim for cephalad side of transverse process. 6. Inject LA into fascial plane between erector spinae and transverse process, volume 20-30 milliliters. Complications. 1. Pneumothorax. 2. LA toxicity. 3. Sympathetic block. 4. Epidural spread. Tips. 1. Can be performed bilaterally and at multiple levels. 2. Useful option if paravertebral block is too Useful option if paravertebral block is too difficult. Wrist block. Indications. 1. Analgesia or anesthesia for hand surgery. Landmark technique. 1. Median nerve, between palmaris longus and flexor carpi radialis. Inject 2-3 cm proximal to wrist creases, 1 cm depth. 2. Ulnar nerve, between ulnar artery and flexor carpi ulnaris. Inject 1-2 cm proximal to wrist creases, 1 cm depth. 3. Radial nerve, SC3 -5 cm proximal to wrist joint, infiltrate SC2 -3 cm proximal to anatomical snuff box. Tips. 1. Avoid median nerve block and wrist block in patients with carpal tunnel syndrome, nerve blocks, central neuraxial blocks, spinal and epidural anatomy. 1. Spinal cord terminates at L1 in adults and L3 in infants. 2. Intercristine line, TFTRS line, is at L4 level. 3. C7 is the most prominent spinous process. T7 is at the inferior angle of the scapula level. 4. Subarachnoid space ends at S2 in adults, and is lower in children. 5. Subarachnoid space extends laterally along nerve roots to dorsal root ganglia. 6. Subdural space is a potential space between dura and arachnoid. 7. Epidural space lies between vertebral canal walls and spinal dura mater, occupied by areolar tissue, loose fat, and internal vertebral venous plexus. 8. Ligamentum flavum is thin in cervical region, thickest in lumbar region, 2 -5 mm, spinal or subarachnoid block. Indications. 1. Lower abdominal surgery CS, inguinal hernia. 2. Lower limb surgery. 3. Perineal surgery. Landmarks. 1. Spinous processes of lumbar vertebrae. 2. Line joining iliac crests, TFTRS line, technique. 1. Patient sitting or lying on side. 2. Mark line joining iliac crests. 3. Identify spinous process at this level, L3/4 interspace, midline technique. 1. Insert needle in midline with 15 degrees cephalad 2. Advance until click or pop is felt dura pierced, at 4 -6 cm depth. 3. Confirm free flow of CSF. 4. Aspirate gently before and after injection, paramedian technique. 1. Insert needle 1 -2 cm lateral to upper border of spinous process. 2. Contact lamina, withdraw slightly. 3. Reinsert needle 15 degrees medially and 30 degrees cephalad. 4. Advance until click or pop is felt. Relative contraindications. 1. Azor mitral valve stenosis. 2. Hypovolemia. 3. Previous back surgery. 4. Neurological disease. 5. Systemic sepsis, absolute contraindications, local sepsis, patient refusal, anticoagulation, local anesthetic drugs and doses for spinal anesthesia. 1. Dosing depends on age and pregnancy. Older patients need less drug due to degenerative changes and increased neural sensitivity. Pregnant patients need less due to epidural vein engorgement. 2. Bupivacaine 0.5% is usually used. Heavy is hyperbaric with 8% glucose, plain is isobaric at body temperature. 3. Hyperbaric solutions can achieve higher block and influence height with position changes. 4. Volume. 2.5 to 3.0 ml hyperbaric solution reaches T6, T10 in non-pregnant young adults. Pregnant patients require less, 1.8 to 2.2 meters L. Plain LA volume tends to be higher. 5. Lidocaine, associated with cauda equina syndrome, transient radicular irritation, and transient neurological symptoms. 6. Ropivacaine, can be used, shorter duration than bupivacaine, no heavy preparation. 7. Opioids, often added to improve block quality. 8. Ensure drug preparations do not contain preservatives. Clinical tips. 1. If difficulty at L3/4, go down, not up, due to variable conus termination. 2. Surface identification of L3/4 interspace is inaccurate. 70% of clinicians mark it as a higher space. Ultrasound can improve accuracy. 3. Sitting position increases CSF pressure and improves CSF flow with fine needles. Easier to find, midline in obese patients. 4. Lateral position offers patient comfort and possibility of sedation. 5. Problems often due to lumbar spine not flexed enough, short introducer not inserted enough, too flexible needle. 6. In elderly, osteophytic patients, consider 22G quincunxit needle. PDPH is rare in this group. 7. Hitting bone, superficial level, likely top of spinous processes, midline, deep level, likely lamina, may be out of midline. Ask patient to identify side and adjust, accordingly. Complications. 1. Hypotension, due to sympathetic block, Bradycardia if block extends to mid-thoracic region, can progress to cardiac arrest. 2. High block, compromising breathing, may extend to total spinal with loss of consciousness, apnea, and cardiorespiratory arrest. 3. Urinary retention. 4. Nerve damage. 5. PDPH. 6. Infection, abscess, meningitis. 7. Spinal canal hematoma, more likely in patients with coagulation disorders, can cause spinal cord compression and permanent paraplegia if not urgently decompressed. Incidence of complications. 1. Permanent injury. 125, 000 150, 000. 2. Death or paraplegia. 150, 0001, 140,000. 3. Higher incidence in elderly patients with epidurals and patients undergoing CSES, ultrasound for central neuraxial block. 1. Used to pre-scan anatomy and identify landmarks before procedure. 2. Allows identification of midline, accurate spinal level, depth to ligamentum flavum, angle of insertion widest interlaminar space. 3. Increases success, decreases technical difficulty, needle reinsertions, and risk of traumatic procedures. 4. Particularly useful in patients with abnormal anatomy or non-palpable landmarks. 5. Difficult skill in challenging patients, e.g., morbid obesity, requires practice. 6. Can be used as a teaching aid to demonstrate anatomy and confirm correct insertion point and depth. Epidural analgesia. Benefits. 1. Reduces acute and chronic pain after surgical procedures. 2. Can reduce length of hospital stay. 3. Reduces incidence of postoperative atelectasis and pulmonary infection, improving oxygenation. 4. Effective pain relief allows patients to cough, breathe deeply, and cooperate with physiotherapy. 5. Epidural analgesia combined with GA reduces pulmonary complications in thoracic, abdominal, and lower limb procedures. 6. Of proven benefit in patients with pulmonary disease. 7. Attenuates hypercoagulable response to surgery, improving fibrinolytic function. 8. Reduces pain and opioid consumption, and duration of ileus and time to first flatus. 9. Reduces surgical site infections, contraindications. 1. Patient refus L. 2. Staff untrained in epidural care. 3. Local or general sepsis. 4. Hypovolemia. 5. Coagulation disorders. 6. Concurrent treatment with anticoagulant drugs. 7. Some central neurological diseases, no survival benefit. 1. No survival benefit in high-risk patients despite benefits in pain relief and respiratory function. Troubleshooting. 1. Breakthrough pain, add regular POPRIV NSAID and paracetamol, bolus dose, 3 - 5 ml, check connections and insertion site, check block level. 2. Pruritus, give naloxone, 50-100 micrograms, consider adding 300 micrograms to infusion fluids or removing opioid, antihistamines may give relief. 3. Hypotension, check fluid status, check block height, reduce infusion rate, raise legs, give fluid bolus, and vasopressor if acute severe. 4. Motor block, reduce infusion rate, consider reducing LA concentration. Table 41.8 Complications of epidural analgesia, complication, dural puncture, incidence percent. 0.16 to 1.3, management, bed rest, analgesia, hydration, blood patch, headache, not PDPH, nerve or spinal cord injury, catheter, migration, epidural abscess and hematoma, respiratory depression, hypotension, pruritus, 0.016 to 0.56. E 0.15 to 0.18, 0.01 to 0.05. 0, 0004, 0, 03, 0.13 to 0, 4. Decrease in opioid concentration may be required. V fluids T vasopressors. Temporarily, reduce or stop infusion. Naloxone IV 50-100 micrograms T antihistamine. Catheterization. Check for catheter migration. Temporarily cease infusion. Consider epidural hematoma. 3:30. 10. Urinary retention 1030, in. 3. Motor block, Shug. S.A., Palmer, G.M., Scott, D.A., et al. Acute Pain Management, Scientific Evidence 4th edn. Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine, Melbourne, 2015. Drugs used for epidural analgesia. 1. Combination of opioid and low-concentration LA solution given by continuous infusion. 2. Common mixtures, bupivacaine 0.125% with fentanyl 5 micrograms ml or diamorphine 125 micrograms ml, bupivacaine 0.1% with fentanyl 5 micrograms ml or diamorphine 100 micrograms ml, bupivacaine 0.0625% with fentanyl 2 micrograms ml or diamorphine 50 micrograms ml. 3. No universally accepted optimal combination. 4. Infusion rates vary according to concentration, surgical site, and catheter placement. 5. Usual infusion rates, -8 -15 ml/h for adult patients, 4 -8 ml/h for patients over 70 years old. 6. Some anaesthetists reduce or avoid epidural opioids in the very elderly, using LA solutions only. Intrathecal opioids. 1. Administered intrathecally with LA during spinal anesthesia. 2. Delivered directly into CSF, avoiding epidural fat and blood vessels. 3. Doses are much smaller compared to epidural or parenteral routes. 4. Lipid solubility affects onset and duration, more lipid soluble, rapid onset, short duration, less lipid soluble, slower onset, longer duration. 5. Pethidine has LA and opioid properties, can be used as sole drug for spinal anesthesia. 6. Delayed respiratory depression can occur with less